Hey everyone, and welcome to this explainer. Today, we are unpacking the incredibly complex mechanics of human reproduction. We're going to explore the entire conception spectrum. So we'll start by looking at the biological hurdles of achieving a pregnancy, and then we'll shift gears entirely to look at the precise science of preventing it. We have got a ton of fascinating medical mechanics to cover, so let's just jump right in.
All right, here's our roadmap for today. We'll start with defining and causing infertility, then move into evaluating fertility issues and effective infertility treatments. After that, we'll cover contraceptive methods and efficacy, and finally wrap up with emergency contraception essentials.
Kicking things off with Section 1, Defining and Causing Infertility. Let's look at the biological roadblocks to pregnancy. So, infertility is a condition that affects a staggering 72 million couples worldwide. But how do we actually define it clinically? Well, time is the primary diagnostic factor here. The clinical definition is simply the inability to achieve pregnancy after 12 solid months of unprotected intercourse. Now, why 12 months? Because naturally, about 85% of couples will conceive within that first year. If that one-year milestone comes and goes without a pregnancy, that's the clinical trigger for us to start investigating.
But wait, that 12-month rule? It is definitely not universal. Clinical guidelines aggressively shrink that waiting window based on maternal age. For patients under 35, sure, you wait the standard 12 months. But if a patient is between 35 and 40, that evaluation window gets cut in half to just 6 months. And over 40, 0 months. You literally evaluate immediately. And the urgency makes total sense when you realize that fecundability, which is the probability of achieving a pregnancy in a single menstrual cycle, drops drastically as we age. By age 44, it plummets by up to 59%. So time is quite literally of the essence.
Now, this is absolutely crucial to understand. Historically, society placed the burden of infertility almost entirely on women, right? But the biological reality tells a very different story. Female factors account for about 30 to 40% of cases, but male factors actually represent 40 to 50% of the etiology. Plus, another 20 to 30% involve a combination of both partners. It's a really striking reminder that achieving pregnancy requires two highly complex systems working perfectly in tandem. It is a shared biological burden. Okay, moving on to Section 2, Evaluating Fertility Issues. Let's talk about diagnosing the mechanical and hormonal system.
I'm sure you've heard the common advice to track basal body temperature to get pregnant, right? Well, scientifically speaking, it's virtually useless for timing intercourse. Why? Because that temperature spike you're looking for is caused by progesterone, which is only released after ovulation has already occurred. You can't use temperature tracking to predict an event that's already finished. It's like checking the weather forecast for yesterday. Instead, we use urinary LH kits. These actually detect the beginning of the luteinizing hormone surge. This gives couples a true heads up, allowing them to effectively time intercourse on the day of the surge and the day after. We want prediction, not a post-game recap.
Now, evaluating the fallopian tubes is typically done using an HSG, or a hysterosalpingogram. And here is a super fascinating clinical pearl for you. The HSG test isn't just diagnostic to see if the tubes are open, it's actually therapeutic. Studies show that pregnancy rates genuinely spike immediately following an HSG test. The working theory? The oil-based contrast dye used during the imaging literally flushes out microscopic mucus plugs in the fallopian tubes. It essentially clears the runway. How cool is that?
But when we're doing the initial workup, efficiency is everything. So clinical guidelines explicitly tell us to avoid certain invasive or niche tests right out of the gate. We do not jump straight to diagnostic laparoscopies, endometrial biopsies, or DNA sperm fragmentation. Those are heavily reserved for highly specific scenarios, like recurrent pregnancy loss. Initial testing is strictly about nailing down the basics: ovulation, tubal patency, ovarian reserve, and a semen analysis. Keep it simple, keep it focused.
All right, let's jump to Section 3, Effective Infertility Treatments. It's time to bypass those biological roadblocks.
Once we've identified the exact roadblock, treatment is definitely not one-size-fits-all. It's highly targeted. For instance, if a patient has PCOS, the first-line treatment is actually a drug called letrozole to induce ovulation. It's now preferred over clomiphene. But if it's hypothalamic amenorrhea, which we often see in extreme athletes, the literal medical prescription is weight gain and decreased exercise. However, if we're dealing with severe male factor infertility where the sperm count is critically low, we bypass all of that and jump straight to IVF combined with ICSI. That's where a single sperm is micromanaged and injected directly into the egg.
Now, what if a patient has a hydrosalpinx? That's a blocked fluid-filled fallopian tube. This step-by-step clinical protocol is wild because it shows why we absolutely must surgically clear defective plumbing before we ever implant an embryo via IVF. Step 1, do not try to repair it. It has a terrible failure rate and heavily invites ectopic pregnancies. So, step 2, remove it entirely through a salpingectomy. Why? Because the fluid inside that blocked tube can leak back into the uterus and it is highly toxic to a developing embryo. We literally have to surgically clear that toxic environment out completely before moving to step 3, which is proceeding with IVF.
Okay, let's totally flip the script for Section 4, Contraceptive Methods and Efficacy. We are diving into the precise science of preventing conception.
When it comes to preventing pregnancy, user-independent methods absolutely crush daily pills or barriers. The subdermal implant? It boasts a staggering failure rate of just 0.05 per 100 women per year. It, along with the hormonal IUD sitting at 0.1, represent what we call LARCs, or long-acting reversible contraceptives. Once they're placed, human error is completely removed from the equation. Compare that to the daily pill, the patch, or the ring. Those sit around an 8% failure rate, and that is entirely due to user compliance, like just forgetting to take a pill. And male condoms, they sit at a 17 to 21% failure rate, though it's super important to note they remain the only method that actually protects against sexually transmitted infections.
So how exactly does the daily pill pull this off? Well, by feeding the body continuous hormones, the pill essentially hijacks the brain's negative feedback loop to pause the natural ovulation cycle. The estrogen component continuously suppresses follicle-stimulating hormone, or FSH. And without FSH, no dominant follicle ever develops. Meanwhile, the progestin component goes to work suppressing luteinizing hormone, or LH, which stops ovulation dead in its tracks. And as a secondary backup, progestin thickens the cervical mucus to create a hostile physical barrier for sperm. It's an incredibly clever, highly effective chemical blockade.
Now, nature actually provides its own built-in contraceptive via suckling-induced hormone suppression, which we call lactational contraception. But, and this is a massive but, it only works if 3 incredibly strict criteria are met flawlessly. Rule 1. The infant must be exclusively breastfed. That means 0 formula and no pacifiers to stretch out feeds. Rule 2, the mother's menstrual cycles must not have resumed. And Rule 3, this is only valid within the very first 6 months postpartum. If you break even one of those rules, the contraceptive effect vanishes instantly.
Finally, we reach Section 5, Emergency Contraception Essentials, the final mechanical intervention.
120. That number right there, that is your golden window. Every single emergency contraceptive method works for up to 120 hours, or exactly 5 days after unprotected intercourse. Clinical guidelines are crystal clear on this. Do not delay, do not wait around for a pregnancy test, and do not waste time performing a clinical exam before prescribing. If the patient is anywhere within that 120-hour window, you intervene immediately.
So what are our actual options here? Well, the copper IUD is hands down the undisputed champion of emergency contraception. It is highly toxic to sperm and prevents both fertilization and implantation, boasting a failure rate of less than 1%. But if we're looking at oral options, ulipristal acetate is the most powerful pill-based intervention for stopping an impending ovulation. It's a single 30 milligram dose that aggressively blocks endogenous progesterone receptors, which actively inhibits that LH surge we talked about, delaying ovulation entirely.
But, and this is crucial, we have to talk about how body type impacts these interventions. Clinicians have to navigate the reality that body weight significantly alters hormone absorption. Because of this, the non-hormonal copper IUD is the absolute gold standard and the preferred option for overweight or obese patients. Its mechanical and chemical effects don't care about a patient's BMI at all. That being said, guidelines enforce a vital rule. You must never deny hormonal options to overweight women if they request them. Why? Because even with reduced efficacy, taking the pill still offers a far better clinical benefit than doing nothing at all.
As we wrap up this explainer, I want to leave you with something to chew on. We've just spent all this time looking at how perfectly we can hijack hormonal loops to prevent a pregnancy, and how surgically precise we can be in extracting eggs and injecting sperm. Yet if we possess the clinical knowledge to manipulate ovulation and conception with such unbelievable pinpoint accuracy, why do 72 million couples still face the agonizing burden of unexplained infertility today? Despite our absolute mastery over contraception, the origins of human life still hold some profoundly deep biological mysteries that we are only just beginning to solve. Thanks for learning with me today. Keep asking questions, and I'll catch you on the next explainer.